Thank you very much, and thank you all for coming back for the last session of the day. Our learning objectives for this session, we'll discuss the value of ultrasound to diagnose acute pelvic pain in the young woman. We'll describe the ultrasound technique for optimal assessment, and I'll share with you some of our experience with endovaginal ultrasound in this patient population, and we'll identify the imaging features of acute conditions of the ovaries, the uterus, and the adnexa. Now, acute abdominal and pelvic pain, as we said earlier, is one of the most common presenting symptoms to our emergency rooms, accounting for about 7% of all emergency department visits. And acute pelvic pain in the young woman is an important subset because many causes, such as pelvic inflammatory disease or endometriosis, can lead to infertility, while other causes, such as ruptured ectopic pregnancy, can lead to death. But determining the cause is a clinical challenge, and we have to consider a number of different possibilities, including hemorrhagic ovarian cysts, pelvic inflammatory disease, and ectopic pregnancy most commonly, but there are other important rarer causes, some of which may require immediate surgical attention, such as ovarian torsion. There's also endometriosis, degenerating fibroids, and then there are some patient populations where there are specific, though somewhat unusual diagnoses that we should consider, and an example would be in postpartum patients who may have endometritis or perhaps an acute ovarian vein thrombosis. And then very importantly, even though we may be focusing on a gynecologic cause, there are a whole range of non-gynecologic conditions that can also cause acute pelvic pain in the young woman, and common causes would be conditions such as appendicitis, diverticulitis, and ureteric stones or renal colic, and there are, of course, many other causes to consider as well. So if you base your diagnosis just on the history, physical examination, and some simple laboratory tests, your diagnosis in this patient population will be inaccurate. And imaging is critical to management, and where I practice, we believe that in young women, ultrasound should always be the initial imaging test. It's accurate, it's safe, it's inexpensive, it's available, it's portable, and importantly in this patient population there's no ionizing radiation. And in our practice we routinely include an endovaginal scan unless there's a reason not to perform one. So here's an example. The endovaginal scan allows placement of a high frequency probe closer to the pathology. So often we get more definition. Where is the pathology arising from? Is it the ovary, the uterus? Is it outside the ovary? But it also allows this dynamic assessment. So I'm going to stop the video for a moment. And if we look at this is the ovary, and this is a thick wall cyst adjacent to the ovary or arising from the ovary in a young woman with a positive beta HCG. And the question is this an ectopic pregnancy or is it a corpus luteal cyst? And I would challenge anybody from this static image to make that distinction. Both have a very similar appearance. Some people would advocate for color Doppler, with the idea being that an ectopic may have a so-called ring of fire, but a corpus luteal cyst in early pregnancy will also demonstrate a ring of fire. So by probing with the probe, or using very gentle pressure with the endovaginal probe, we can create dynamics between this cyst and the ovary and show clearly that this thick wall cyst is moving separately from the ovary and is therefore likely not arising from the ovary and is almost certainly an ectopic pregnancy rather than a corpus luteal cyst. Contrast that with this case, where we have the uterus on your left and a solid left adnexal mass. And I'll just go back again. A solid left adnexal mass. And in this case, when we probe with the probe, for some reason the video is not playing, we can see that that mass moves in concert with the uterus and is therefore likely arising from the uterus, and using the laws of probability is probably a subserosal fibroid rather than an ovarian mass. You would still like to demonstrate a normal ovary on each side. And here's a third example. In this case, the internal probe is held completely stationary, but you use your free hand to palpate this large echogenic mass at the uterine fundus. And you can see that this mass is moving separately from the uterus. It could be a large fibroid on a pedicle, that's possible, but it's more likely to be arising outside the uterus, and this was a large ovarian dermoid or mature teratoma. So, I love CT, so I'm not trying to put the CT scanner out of business, but in young women it does involve ionizing radiation, but it can still be performed if the ultrasound is equivocal. So you do your ultrasound examination, you look at the uterus and ovaries. If they're normal or show just a simple cyst, you look beyond them for other pathologies, but you shouldn't spend long periods of time. If the pathology doesn't declare itself quickly and the symptoms require it, then by all means do a CT scan. And MR may also provide valuable information, but at least in our practice, it's not always easily accessible in an acute setting, and it's probably not cost effective when less expensive modalities will likely yield the answer. So here's our typical presentation. A young woman comes to the emergency department with acute pelvic pain. Very typically, where I practice, a pregnancy test is performed and a pelvic ultrasound is ordered. And if the pregnancy test is positive, the history on the requisition invariably reads rule out ectopic pregnancy. And if the pregnancy test is negative, the history invariably reads rule out ovarian cyst. And for the rest of this presentation, I'm going to discuss just those cases where the pregnancy test is negative. So I'm not going to discuss ectopic pregnancy. So here's maybe the most important take-home point if you're going to do ultrasound in this patient population. If there's pelvic pain and you've done the ultrasound and the uterus and ovaries are normal, keep looking for other pathology. Or if you do the ultrasound and there is an ovarian cyst, but it's a simple cyst or a minimally complex cyst, these are normal findings and are probably not the cause of the patient's pain, so you keep looking. So as a little reminder, this is the take-home message: keep looking. Now, ovarian follicles and cysts. If a mature follicle fails to ovulate, a follicular cyst forms, and it's often greater than 2.5 or 3 centimeters in size. These cysts often hemorrhage into themselves, a so-called hemorrhagic ovarian cyst, that can be painful, but it's usually relatively mild and self-limiting pain. So if the patient is in extreme pain, it's almost certainly not related to that hemorrhagic cyst. Sometimes a functional corpus luteum cyst develops, and if that persists and grows, it may rupture and you may get hemoperitoneum. And this frequently causes very, very severe pain. So here we are. This is a young woman with acute pelvic pain, and we see this simple ovarian cyst. It has an imperceptible wall. It measures about 2.5 centimeters in diameter. There's nice through transmission, and you can see the cyst is displacing some ovarian tissue. And we know that's ovarian tissue because we can see small follicles within that tissue. This is a normal finding in a young woman. It's a dominant follicle, and it should not be blamed for the patient's pain. We should also be familiar with mid-cycle pain, Mittelschmerz, ovulation pain. So it's important to take a history from the patient and understand where they are in the menstrual cycle, and could it be something as simple as ovulation pain that will take care of itself. And if the pain is severe in these patients, you still need to satisfy yourself that you're not overlooking more serious pathology. This is the next stage. So this is a follicle with internal hemorrhage, and it's fairly acute internal hemorrhage that shows these fibrinous strands or lace-like appearance. These cysts can be painful when the hemorrhage first occurs, but it's usually self-limiting pain. And again, if the pain is severe or if the pain has been prolonged, you should satisfy yourself that there's no other pathology. This is a more mature hemorrhagic cyst, which if you're not familiar with it, can be sometimes confusing. So this is organized blood clot now, the solid-looking component that's retracting away from the cyst wall. So you get this appearance of retractile blood clot. And if you're concerned that this component might be solid, viable tissue, you can always put on color or power Doppler and try and satisfy yourself that there's no flow within that component. Once a hemorrhagic cyst reaches this stage of maturity, it's probably not painful and not tender. So again, be careful that you're not missing something else if you see a cyst with that appearance. And this is using the color Doppler to try and show that there's no flow within that solid appearing component. This is the extremely painful situation now, and I've seen many young women wheeled in on a stretcher. They're sitting up, they're holding their side, they have difficulty breathing, and because of irritation from hemoperitoneum. So this is, we see the uterus there, there's an enlarged ovary, there's a cyst on it, but note how ill-defined the margins of that ovary are, and there's a lot of additional material around the ovary that we'll look at a little later. There's free fluid, and then we follow up into the right flank, and we see that there's free fluid in the upper abdomen. And if you turn up the gains on your ultrasound equipment, you'll see that that isn't simple free fluid, it's invariably particulate. And this is the hemoperitoneum that's irritating the diaphragms and is causing pain and making it difficult for the patient to breathe. The first thing you must do in this situation is ensure that the beta-HCG is negative, because the first diagnosis you would consider in this situation is a ruptured ectopic pregnancy. When we go on and do the internal scan, we have images of the right and left ovary. They're labeled for you. Note how ill-defined the ovaries are in this case. That's because there's organized blood clot surrounding both ovaries. They're ill-defined, and we have this situation of probably a ruptured cyst on the right ovary with hemoperitoneum that has spread over into the left adnexa. Here's another example. I show it to you because of this very classic appearance of acute blood clot in the cul-de-sac. And again, if you probe with the probe, this material will behave like jelly. It has a gelatinous appearance and reaction. And always look up, even if a pelvic ultrasound is ordered, it's often very helpful to look up into the flanks. And here we are looking in Morrison's patch, and you see that the hemoperitoneum has a volume that has spread up the paracolic gutters into the upper abdomen. Again, ensure that the pregnancy test is negative. And here, when we look in the right adnexa, we see again the origin of the ruptured ovarian cyst, all that echogenic material in the middle of the ovary. In fact, it's difficult to make out normal ovarian tissue. So moving on then to another common cause of acute pelvic pain, pelvic inflammatory disease. Often the clinical presentation is vague and the diagnosis can be difficult. We look for fever, pain, purulent vaginal discharge, cervical motion tenderness on clinical examination, and usually the diagnosis is made with microbiology by taking cervical swabs. But we're also invariably asked to image these patients because we're looking for complications of pelvic inflammatory disease, maybe tubo-ovarian abscesses that may require interventional drainage to try and treat the infection and the abscess. Ultrasound is accepted as the primary imaging modality in these patients, and because we're doing ultrasound, we should try and be familiar with some of the early signs of pelvic inflammatory disease. So we should try and look for thickened tubular adnexal structures, look for central fluid in the thickened structure, so early pyosalpinx. There may or may not be free fluid. Look for increased adnexal volume in general, so ill definition of the ovaries, thickening around the ovaries, periovarian inflammation. And with ultrasound, we should be familiar with the appearance of inflamed fat. We're all familiar with that appearance on CT, so-called strangling of fat, but we should also be familiar with it on ultrasound. And on ultrasound, it appears as mass-like echogenic fat that will be tender to palpation. Remember that pelvic inflammatory disease is an ascending infection, spreads into the adnexa, and then we see that increased adnexal volume, tubular thickening, and then ultimately swelling of the whole adnexa, and then a tubo-ovarian abscess develops. And it's called a tubo-ovarian abscess because the ovary gets incorporated into the inflammatory process, and it can be very difficult to distinguish the ovary from the entire adnexal mass. So here's a CT. This CT was done to rule out acute appendicitis, and ultrasound wasn't performed, and this is not something that we would advocate, but sometimes this still happens where you'll have a young woman and a CT will be ordered straight away. And when the CT was done, we see increased adnexal volume bilaterally. There's some low attenuation there. And then if we look, we can see inflammation back in the pouch of Douglas. And if we look carefully in the low paracolic gutters on each side, I think you'll agree with me that we see some inflammatory change there and thickening of the lateral conal fascia. Now, to try and demonstrate on ultrasound, this is a transabdominal scan. In transverse on your left and sagittal on your right, we can see this inflamed fat. See how the bowel loops are pushed away from the anterior abdominal wall, and on palpation, that echogenic fat will have a mass-like response when you palpate with the transabdominal probe. And on an internal scan, we see the uterus in transverse, and again we're seeing that uterus so beautifully because of the echogenic fat surrounding it, and there'll be a lot of tenderness and discomfort and any manipulation of the internal probe. Now, these video clips are an effort to show the early stages of pelvic inflammatory disease. And if we look here in the right adnexa first, we see this thickened tubular structure which leads to a very easily distinguishable ovary on the right side, and similarly on the left, a thickened tubular structure which leads to a very normal appearing ovary on the left side. As we look carefully at those tubular structures, we don't see any central fluid. And we're interpreting this in light of the clinical presentation. Sometimes, if the findings are subtle and we're unsure, you can put on color Doppler, and often you'll see increased flow in that thickened tubular structure, and that will add confidence to the diagnosis of early pelvic inflammatory disease. And if the clinician hasn't already considered that diagnosis in a case such as this, then perhaps microbiology should be performed in an effort to make the diagnosis. So remember the use of color Doppler. This is the next stage then in early pelvic inflammatory disease, where we see the thickened tubular structure, but now we see some central fluid. The ovary is still easily distinguishable here. This is the early pious alpings on the right, and then if we just let the video play again on the left adnexa, this is the central fluid on the left. Note the fluid is echogenic, so these are early pious alpinges, and we can still distinguish the ovary. Here's a static image showing a more advanced pious alpings, clearly a tubular structure. We see internal echoes, so an acute pious alpings. And then the final stage is where we see development of a tubo-ovarian abscess on the left, and on the right side here, an inflammatory mass, but difficult to distinguish the ovary. I'll see if I can get it to play down. So there's an inflammatory mass here. It's very difficult to make out the ovary. And when we look in the left adnexa, we already have a tubo-ovarian abscess, and normal ovarian tissue cannot be seen on that left side. And often the transabdominal scan gives a very good overview when we get advanced bilateral tubo-ovarian abscesses, as in this case, where we see the uterus, bilateral cystic adnexal masses with a fluid debris level here on the left side. Now, there is a syndrome that was described many years ago in 1920, the Fitzhugh-Curtis syndrome, and this is where patients developed acute right upper quadrant pain from ascending pelvic infection. So the infection travels up the paracolic gutters. It used to be thought to be more common with gonorrhea, but now we know that chlamydia is more common at a ratio of about 5:1. And if women with pelvic inflammatory disease are surveyed, up to 15% of women with pelvic inflammatory disease will experience right upper quadrant pain. We don't often image to look for it. Usually we're imaging for a cause of right upper quadrant pain, like this morning's talk, acute cholecystitis, but sometimes we stumble across the appearance. And here's an example where we see this subcapsular enhancement all around the liver. So you get a capsulitis of the liver, and that's what's causing the patient's pain and tenderness. And it's not unique to pelvic inflammatory disease. Here's another condition, a patient with a perforated duodenal ulcer and free air, where we see a similar subcapsular enhancement from irritation from gastric juices. Often seen better if you do have a study in an arterial phase or a portal inflow phase, such as the case I'm showing you currently. Ovarian torsion I'll touch on quickly because I have a hunch that Dr. Mann will probably talk about this as well in the pediatric group. Again, the history is important. A sudden onset of unilateral pelvic pain. Often the patients are sweating, bent over, nausea, vomiting. It's an important diagnosis to make quickly because it necessitates surgical intervention. And except in children and young women, there's usually an underlying mass, and the mass we all know about, torting, is a dermoid cyst or mature teratoma. You should look for unilateral ovarian enlargement, peripheral follicles. There's edema of the ovarian stroma, so the follicles are pushed peripherally. It's worth looking for the twisting sign to actually look for the torsion in the pedicle to the ovary. And the learning point here is that doctor is only helpful if it's absent. Don't let the presence of flow rule out an ovarian or adnexal torsion, because sometimes flow can be preserved. Here's a grayscale image of a fairly typical example, edema of the ovarian stroma. The follicles are pushed peripherally. And here's an example of that twisting sign where we're scanning along the pedicle and we can see the swirl of vessels. So if you see that, it's very reassuring that there is in fact a torsion. And the way to demonstrate that best of all is, if that is the footprint of the probe, scan in transverse along the torsion. That's what will actually show you the swirl. And it's important to remember that if you're trying to demonstrate that sign. Here's an example where color Doppler was helpful. You'll notice we're using the same field of view for the left ovary and the right ovary. We're using the same color Doppler scale, and we're seeing flow easily in this ovary, and flow is absent in the enlarged ovary. But here's another example where again we're using the same field of view. We can see that the enlarged ovary has a large cyst on your left. And when we do Doppler, we can clearly demonstrate arterial flow in that ovary, but that should not reassure us that it is not torted. So this was a woman who had a sudden acute onset. She was at work, she was typing away, and within 5 minutes was bent over, had to go and lie down. Her husband was called. She was brought to the emergency room within about an hour and a half or 2 hours, and this was a surgically proven ovarian torsion, even though arterial flow is demonstrated in the ovary. Now, there is another condition which can mimic ovarian torsion, but the history is different, and that's massive ovarian edema. Again, you get fluid retention in the ovarian stroma. It's a rare condition. It happens often in young women, so the population we're talking about, but often young women who are pregnant, who are undergoing ovulation induction, and it invariably occurs in the right ovary. Nobody's quite sure what the pathophysiology is, but maybe it's a recurrent partial torsion, and it's important to recognize the condition because many gynecologists will opt to follow these patients conservatively rather than perform surgery. And this is an example. This patient had subacute or chronic pain for about 6 weeks. And when we image the ovary, you can see it's a massive ovary. It's about 7 centimeters in diameter. There's edema of the stroma. We see the peripheral follicles, and then we put on Doppler, and in fact, there's increased flow in that ovary relative to the normal side. So this is massive ovarian edema rather than ovarian torsion. Ovarian hyperstimulation or ovulation induction, usually iatrogenic, and there's a new group of patients we're seeing in our practice now with this condition, which was something I learned within the last few years, and I'll show you an example of that. We're all familiar with the syndrome, massively enlarged cystic ovaries, weight gain, ascites, pleural effusions, and in advanced stages, volume depletion, hypertension, and oliguria, and often a very painful condition with abdominal distension and nausea. Just to show it's been around, this is a very old ultrasound image, just a transabdominal scan just below the umbilicus, and we see these very large ovaries touching in the midline, and then you take the history and realize that the patient is on ovarian stimulants. But this is the case where I learned from. This was an 18-year-old woman with a new diagnosis of Hodgkin's lymphoma, and I was interpreting this staging CT scan, and the teaching point is I saw the lymphadenopathy in the mediastinum, and then I glanced quickly through the scan, and I said, well, this doesn't really look great, because I saw the pleural effusions, I saw the free fluid in the abdomen, and I saw these large pelvic masses. And then I said, my goodness, they look very much like hyperstimulated ovaries. And I thought to myself, but she's only 18, it can't be. And then I went into the medical record. And of course, what's happening here is there's harvest of ova for future fertility before she goes on chemotherapy. So she was on a gonadotrophin releasing hormone, and these were in fact hyperstimulated ovaries in a patient with a new diagnosis of lymphoma. Endometriosis, you'll often get a helpful history of dysmenorrhea and infertility, but remember that most patients with endometriosis will have a normal ultrasound unless you look very, very carefully. So we're all familiar with ultrasound of endometriomas, these cysts with uniform low-level internal echoes that can be bright echogenic foci in the wall, and some lesions will be multiloculated and will have some wall irregularity. Endometriosis, chocolate cyst, this is a pathologic example of the altered blood products in an endometrioma. And on ultrasound, it is a very classic and typical appearance of uniform low-level internal echoes. There'll be no internal vascularity, and these cysts will be, again, compliant on probing with the probe. So we will be able to press on the cyst, and there'll be some give in the cyst, so it's not a solid mass. Here's a slightly more complex endometrioma. It's multiloculated, but again, shouldn't really cause any confusion. Here's a transabdominal scan on a young woman who has recurrent pelvic pain, and we see this cyst that looks very much like an endometrioma, and this lesion demonstrates these tiny echogenic foci in the wall of the cyst, which adds some confidence to the diagnosis. Now, this is something we should also be looking for in patients with pelvic pain. We see relatively normal uterus and ovaries, but we should look beyond the uterus and ovaries, and this is endometriotic plaque along the sigmoid colon, on your left in sagittal and on your right in transverse. You can see the colonic lumen there. If I go back, this is gas in the colonic lumen, this is the muscularis propria, and this is the endometriotic plaque along the serosal surface of that rectosigmoid. And this often causes very significant pain and discomfort. This is an interesting case. This was a 28-year-old woman who came to the emergency department at 4 a.m. with acute groin pain. And the emergency docs were worried about a femoral hernia, and they ordered this CT scan. And I interpreted this scan, and I recognized this as a very typical location for a cyst of the canal of Nuck. But when I looked carefully here, this didn't look like a cyst. It was more higher in attenuation than I would expect, and it had a little bit of a spiculated margin, and I honestly didn't know what it represented. I wondered, I think I talked something about a ruptured cyst of the canal of Nuck, but it didn't really make sense. One of the first patients on our ultrasound list that morning was this young woman. And this is a cine loop through the right groin at the site of the patient's symptoms, and you can see this hypoechoic material that's tubular. It conforms to the inguinal canal, and there are even a few little bright echogenic foci in it. And then when you take the history, you realize that this has been a cyclical problem with pain, swelling, and tenderness coming on about a day before the onset of the patient's menses, lasting 2 or 3 days and then improving until the next cycle. And these symptoms had been coming on for about 10 months, about 3 months after cessation of the birth control pill. So I'm really a believer. I love imaging, but clinical medicine is alive and well, and I think the pendulum needs to swing back a little more towards a good clinical assessment of patients and then using imaging to support the clinical impression or refuting it. Just to refresh you on the Canal of Knock, believe it or not, it was first described in 1691 by a Nanton Knock. And what it is an abnormal patent pouch of peritoneum which extends into the inguinal canal and down into the labia majora. And most often what we see there is simply a cyst, but it is a potential site for endometriosis. Now, a few less common things: ovarian vein thrombosis. It's still rare, but maybe less rare than we originally thought. And classically, it's the early postpartum stage, within a week or two postpartum. It is seen sometimes with pelvic inflammatory disease, and it can be seen in patients with gynecologic malignancy and following surgery. And again, most often on the right side. Some patients can be quite sick with this, with pain, fever, chills, nausea, and vomiting, and it can be a little confusing. So here's an example of ovarian vein thrombosis. That's the uterus. There's a tubular structure behind the uterus. Here it is in transverse, and immediately we would all think that that's an acute appendicitis. But the key is, with acute appendicitis, that you'll hear in my next talk, is you have to follow it and see the tip. And when you follow this structure, there was no tip. It went on and on and on up the right flank, and this was an acute ovarian vein thrombosis. So you would not want to send this patient to the operating room for an appendectomy. Occasionally, degenerating fibroids can cause problems. A very common gynecologic neoplasm. Up to 70% of women will develop fibroids at some stage. And when they outgrow their blood supply, they can cause pain. And degeneration of fibroids can be hyaline, can be myxoid, it can be red degeneration, and the red degeneration is the acutely infarcting, painful fibroid, most often seen in pregnancy. And this is an example. This wasn't a pregnant patient. If I remember correctly, she was in her late 30s, presented with very acute abdominal pain, and we saw hemoperitoneum on ultrasound. You see images of the right and left upper quadrants. We see this large fibroid, there's fluid in the cul-de-sac, and we had a kind of a presumptive diagnosis of a ruptured ovarian cyst, but perhaps the woman was a little older than we often see for that diagnosis, and the emergency docs were unhappy and ordered a CT scan, and these are images from the CT which confirm the hemoperitoneum and then shows this very heterogeneous fibroid with a cleft, and the patient went to the operating room, and this is an unusual case of rupture of a degenerating uterine fibroid with hemoperitoneum. You can see the cleft there with the small arrow. Adenomyosis, again, a very common condition. We don't often think a lot about adenomyosis, this heterotopic endometrium within the myometrium, but it does cause painful uterine enlargement, and sometimes that pain can be quite severe. We should look for heterogeneity in the myometrium, and up to 50% of patients will have myometrial cysts, and the uterus will be very tender on palpation. Here's an example. A patient was sent to rule out acute appendicitis. We were able to demonstrate a normal appendix on ultrasound, but we were struck by the appearance of the uterus here, a very heterogeneous myometrium. The uterus was acutely tender, and we couldn't actually discern an endometrium. So we suggested very strongly here in 2007 that the cause of this patient's pain was probably adenomyosis. We next saw the patient again in 2010, and this time a CT scan was ordered, and the CT on this occasion demonstrated the normal appendix, but CT also shows the enlarged uterus and these multiple small myometrial cysts, but more difficult to assess for that uterine tenderness with CT. And then finally, we'll talk about obstruction to menstrual flow as a cause of pain, and that can be primary with an imperforate hymen, or it can be secondary from cervical stenosis, and that cervical stenosis can be from benign or malignant causes. This was a 12-year-old girl who was brought in by her dad because of very severe pelvic pain. And when we look at this suprapubic image, we see the urinary bladder here, and then there's this large structure which is below the level of the cervix and the uterus. So this is blood dilating the vagina from obstruction to menstrual flow, so a hematocolpos. And then this is an older patient who came with quite severe pain. We see the endocervical canal outlined there with the yellow line. There's distension of the endometrial cavity with echogenic material, so a hematometra here. And there was a history of secondary amenorrhea, and this patient had a therapeutic abortion at 16 weeks gestation 2 years previously, so presumably fibrosis of the endocervical canal and now obstruction to menstrual flow. So that brings me to the end of this first part of this discussion. Remember, ultrasound is the first choice, and in our practice, we routinely go on to internal scanning. Remember the value of dynamic assessment with the endovaginal probe. Remember to keep looking beyond the uterus and ovaries if you don't explain the cause of the patient's pain. Remember, if you see hemoperitoneum, make sure the beta-HCG is negative, because ruptured ectopic pregnancy is a serious condition, and if it is negative, then most likely you're dealing with a ruptured ovarian cyst. Remember that flow does not exclude torsion, and remember that a tender uterus is very helpful when considering the diagnosis of adenomyosis. Thank you.